بسم الله الرحمن الرحيم. صباح الخير عليكم. انا احمد البطران، مدرس مساعد كارديولوجي في طب عين شمس. احنا هنا يوم 18 فبراير 2018. محاضرة النهارده عن use of novel oral anticoagulants in AF. اول حاجه النوفل اورال انتي كواجولانتس ار نوت ذات نوفل، لان احنا من سنه 2005 وبقى في ترايلز تو ديفلوب ان الترناتيف اورال انتي كواجولانت از سبستيوت تو وارفرين. وارفرين كدواء معروف من الخمسينات، ومن ده التايم لاين عندنا من سنه 95 ابتدى يبقى في ترايلز بتقول راندمايز كنترول ترايلز بتقول ان فيتامين كي انتاجونست ار superior to aspirin for stroke prevention AF. وعندنا في 2000 كان في ان هي it reduces stroke rates in AF by 2/3، وهم ال oral anticoagulants are the only medications that have been shown to decrease mortality in atrial fibrillation. وابتدى في 2005 بالزيمالجاتران، بس ده was withdrawn because of hepatic toxicity، وبعدين الدابيجاتران، وطلع بعده ثلاثه تانيين اللي هم الريفاروكسبان والايدوكسبان والابيكسبان. In Egypt we have 3 novel oral anticoagulants, one direct thrombin inhibitor which is dabigatran, but the only available dose is 110 mg, and 2 factor 10 active factor 10 inhibitors which are apixaban and rivaroxaban. This table summarizes the relevant clinical data for the 4 novel oral anticoagulants. Dabigatran, which was first validated by the RELY trial. One caveat about it is that it has a renal clearance of 80%, and this is a problem with all novel anticoagulants, is that renal impairment is the main hurdle to the current use. The Dabigatran, which comes with a dose of 150 milligrams and 110 milligrams, both of them were tested in the RELY trial. The 150 milligrams was found superior to warfarin in terms of efficacy and comparable in terms of safety, while the 110, while being just as effective as warfarin, was found to be more safe with less bleeding events. Rivaroxaban, which was tested in the Rocket AF trial, which enrolled the sickest population of AF patients ever in the 4 trials, and it was found to be non-inferior to warfarin. One important thing about rivaroxaban is that it has interaction with diet, is that it has a bioavailability of almost 100% when taken with meals, while only 80% or less when taken without meals. And apixaban, which was tested in the Aristotle trial, and it is so as to say the champion of the NOACs as we have now, because in the Aristotle trial it was superior to warfarin both in safety and efficacy endpoints. It comes with a standard dose of 5 mg twice daily, and it has a reduced dose of 2.5 mg twice daily. But please mind you have to fulfill specific criteria to give the reduced dose of apixaban, which is 2 out of 3, which are age 80 years or more, weight 60 kilograms or less, and creatinine of 1.5 milligrams per deciliter. And there's the edoxaban. We don't have it in Egypt yet. It comes with 2 doses, the 60 milligram and the 30 milligram, which is also once daily like the rivaroxaban. So what are the guideline-based indications for the NOACs? In the 2016 guidelines, there is a marked paradigm shift which took place, in which if you're gonna give an oral anticoagulant, it should be a NOAC unless you have specific indications, which are the valvular heart disease, which have been shrinking over the years. First it was all valvular heart disease, and now it's only moderate to severe mitral stenosis or the mechanical heart valve. This is why you give anticoagulation. This is the CHA2DS2-VASc score. This is all too familiar for you. I won't go into in detail about that. And these are the risk factors. And so you give an oral anticoagulant to a male with a CHA2DS2-VASc 2 or more, or a female with a CHA2DS2-VASc 3 or more. This is the class 1 indication level of evidence A, so this is the strongest recommendation you can get. Slightly less firm recommendation in the CHA2DS2-VASc score of 1 for males and 2 for females, but it's still a class 2A level of evidence B. And now, this is the change in the 2016 AF guidelines, is that when oral anticoagulation is initiated in a patient with AF who is eligible for NOAC, a NOAC is recommended in preference to vitamin K antagonist, and this is class 1 of recommendation level of evidence A. And this is the class 3 recommendation with a note of harm, which was in the Realign trial, because the dabigatran was tested against warfarin in prosthetic valves, and it was found to be associated with more thrombotic events and with more bleeding events. So NOACs are not recommended in patients with mechanical heart valve level of evidence B because of the Realign trial, and moderate to severe mitral stenosis level of evidence C. This is expert opinion, but it is extrapolation from the mechanical valve. This is about there's some controversy regarding that, is whether we should lump both the mechanical valve and the native moderate to severe mitral stenosis in the same category, but for the purpose of the guidelines and for the recommendations we have right now, this is the case. And this diagram summarizes our approach. So first, if you have a mechanical heart valve or a moderate to severe mitral stenosis, the clear recommendation is NOACs are out of the question till now. But if you don't have any of these, you should prefer the NOAC to the vitamin K antagonist. But we have to take into consideration some practical aspects, which is we're in a developing country and these things are pretty expensive. So in which patients would you prefer NOAC? So if you find the INR testing burdensome, if you can't adjust the INR easily in a patient, one clear limitation to vitamin K antagonist is how long would you stay in the therapeutic range. So a time in therapeutic range of 60% or less is ineffective. So these patients you should strongly consider switching to a NOAC. And you have a normal renal function. This is the main caveat even in developed countries, because once you get below 30 milliliters per minute for most of them, 25 for apixaban, they are clearly contraindicated. So an optimal candidate for warfarin up till now is a patient who has renal insufficiency or a patient who's already taking warfarin and doesn't find INR testing burdensome. So it's just as effective. And this is the time in therapeutic range per country in the RELY trial, saying that in some countries like Sweden, where they have the close medical follow-up, it can be achieved in 77% of patients, while in a country like Taiwan, which is still a developed country, you can only find it in 44% of patients. So warfarin is not ideal for everyone.
I'm sorry, ideally, how often should I check for INR in patients with warfarin?
Well, if you have a stable patient, once a month would be okay, but you have to individualize it and tailor it to the patient's needs, especially in the initial dose while you're titrating the dose. And here, this is the RELY data about stroke and bleeding events, is that once you get the time in therapeutic range, 72% or more, they're just identical. But when you get below that, you're in trouble. And what are the current challenges to the use of NOACs? First of all is bleeding in anticoagulated patients. In the past, we used to have no antidote, and physicians were particularly reluctant to prescribe NOACs because there is no reversal agent when the patient gets bleeding. There is an antidote for the bigger trend, which is I'll show you the randomized trials about it. And there is another one, factor 10 inhibitor, and dexamethasone, but there are quite some issues about it. And this is the guideline chart about managing the bleeding in NOACs. If you're minor bleeding, you delay for 1 dose or 1 day. Moderate to severe bleeding, you stop, you give fluids, blood, and treat the source of bleeding. And if severe life-threatening, you should consider prothrombin complex concentrates or the antidote. And these are the trials. Now this is where we stand in 2017, and this idarucizumab is FDA approved. And this is the reverse AD results. The trial for it is that this antidote is given in 2 doses of 2.5 grams, and you see here, I'm sorry, this is in very small print, but immediately you get a reversal of direct thrombin time to normal. Another challenge is PCI in patients in atrial fibrillation, and here the guidelines can distinguish it into 2 categories. First, the acute coronary syndrome and the elective PCI, and there is the estimated high bleeding risk and low bleeding risk based on the slide about the bleeding risk, which I've shown you before. So if you have an acute coronary syndrome, you should give the dual therapy with an oral anticoagulant with aspirin or clopidogrel for 12 months. The difference is how long will you go for triple therapy, 1 month with a high bleeding risk or 6 months with the low bleeding risk. If it's an elective PCI, it's going to be triple therapy for only 1 month. How long will you go on dual of an oral anticoagulant plus an antiplatelet plus an aspirin or clopidogrel? Either 6 months for the for the high bleeding risk or the 12 months for the low bleeding risk. And
Excuse me, when you mean triple therapy, that's okay. When you mean dual therapy, what should we drop? Antiplatelet or anticoagulant?
well, you should stick to the anticoagulant. Which antiplatelet you drop, the guidelines are not clear on that. There are some trials which say a clopidogrel plus oral anticoagulant is more effective, but aspirin plus oral anticoagulant is safer. In clinical practice, what most do would be clopidogrel plus the oral anticoagulant.
That's for 12 months.
For the 12 months, yes.
Then you switch back to oral anticoagulants plus aspirin.
No, for life it's just the oral anticoagulant because the patient comes back to the stable coronary artery disease subset. It would be only the oral anticoagulant for life.
Okay, just one subset. Those people who with acute or subacute stent thrombosis or just some sort of smoky shadow inside the stent. Some people do say that oral anticoagulants, the new NOACs, have a role.
Yes, this is another spectrum. This is not the AF spectrum, and this is the low dose for the rivaroxaban, 2.5 milligrams. And yes, and something I'll touch upon here. This is the Pioneer AF trial, which was in late 2016, early 2017, which tested 3 doses: the coronary dose, which is 2.5 milligram twice daily, plus the dual antiplatelet therapy, versus the standard therapy, the triple therapy. Versus rivaroxaban plus single antiplatelet. And the interesting thing about this trial is that both rivaroxaban arms were superior in terms of safety, but were just as effective. So there may be a role for dual therapy with a NOAC plus single antiplatelet in the future, but this hasn't made it into the guidelines yet. We still need more trials, and I believe there's a similar trial running with the bigger trend.
Only for rivaroxaban.
This has been for the Pioneer AF trial. This is for rivaroxaban. We can't extrapolate it to the rest, and it hasn't made it into the guidelines yet because actually it appeared after the guidelines had already been published. What about cardioversion in NOAC treated patient? In NOACs, just as vitamin K antagonists, you can give anticoagulation for 3 weeks before elective cardioversion and 4 weeks following cardioversion. And an alternative strategy would be to use the TE. Also, an important thing is that you don't have a test to tell you a NOAC is working or not. You have a test to tell you the patient is taking warfarin or not, which is basically the INR. So if you have a doubt about compliance, please use TE. What about patients with stroke with a NOAC? It's just like the vitamin K antagonist. You discontinue. What about thrombolytics? If the patient had stopped taking NOACs 48 hours or more, it is safe to give thrombolytic. Otherwise, it is contraindicated. If you are uncertain, you can use the PTT for acute stroke.
That means if I have a patient on NOAC and he gets an acute stroke, I cannot use it.
Unless he has discontinued the NOAC 48 hours or more previously.
But the window for the stroke is only 4.5 hours.
Yes, so if he is regularly taking the NOAC, the thrombolytic is not an option.
But on vitamin K antagonist, I can actually antagonize it with fresh plasma.
Well, yes, but you can give it once the INR is less than 1.7. This is the limitation here. And if there's uncertainty regarding the last dose, you can use the PTT for the bigger trend. The PT is softer recommendation for the factor 10 inhibitors because it's not that reliable, but what's made it into the guidelines is the PTT for the bigger trend. One option you could use if available is mechanical thrombectomy in this subset patient who is taking the NOAC, but thrombolytic is not an option. What about hemorrhagic stroke? It can be restarted 10 to 14 days after the intracerebral hemorrhage, but this is a really individualized decision based on the patient's status. And what about carotid stenosis? Because of the requirement for dual antiplatelet after stenting, the endarterectomy is strongly preferred. And thank you.
Touching the point you said, carotid stenosis. If I do, if a stent is placed, I need dual antiplatelets. I think that's the same as a coronary.
Yes, but there haven't been trials conducted enough and there isn't enough data to touch on the duration of the dual antiplatelet and triple antiplatelet therapy. It is a bare metal stent, mind you, but we don't have enough data to recommend it. So that's why you should be favoring the side of carotid endarterectomy.
I mean, so as not to use.
Yes, so as not to be obliged to use the triple and then the dual therapy.
I mean, he's an AF patient. So
Yes.
So you do not prefer him to use it to have carotid stenting, but in that so I don't have to use two antiplatelets plus.
Yes, yes. There's more information about that in the ERA practical management document about the use of NOACs in AF patients. There's a 2013-2015 version, and next month we expect the 2018 version to be released in the ERA Congress in Barcelona.
Which when? We have three. Which when? You said the big study is the hero.
Yes, this is a difficult question to answer because they haven't been compared in head-to-head trials, and there's significant difference in the population. In different trials, the Rocket AF are the sickest, but the other ones are significantly more healthy. There is personally, I prefer Pixabem because the trial has shown it to be superior in both efficacy and safety.
That's twice daily dosing.
It is twice daily dosing. But this is specific, basically physician and patient's preference, and we'll need to have more data to come out on that.
Should I restrict a 12-hour period, or is it patient usually takes it 10 a.m. and 12 p.m.?
Well, we should. These have yes, they have the relatively short half-life, and I think we should adhere to that. But the more important issue is compliance. And there is a table in the ERA document which tells you what happens if the patient skips a dose, what if the patient skips two doses.
I'm not talking about skimming a dose. I'm talking about typical Egyptian patient who's never on time.
Well, one in the morning, one in the evening. I think it will. Yeah, it can come.
Thank you.
Okay, thank you.